Good morning, everyone. My name is Haytham Mekawi, consultant in anesthesia and intensive care. Today, we are about to embark on a journey through one of the most classic pediatric surgical conditions, infantile hypertrophic pyloric stenosis. Imagine a tiny baby, only a few weeks old, who suddenly decides that mealtime should look like a scene from a fountain show. Milk goes in, and then it sprays right back out. That, my friends, is not reflux. It is projectile vomiting, and it is the signature act of pyloric stenosis. Now, before we talk about anesthesia, fluids, and all the heroic corrections we do, let us remember the basics. This is not an emergency to rush into. In fact, the surgeon might be pacing, but the anesthetist is the calm hero here. We do not operate until the baby's chemistry looks as elegant as our anesthesia notes, balanced and corrected. By the end of this lecture, you will understand why the baby's body becomes alkaline enough to power a chemistry lab, why the urine first turns into something like seawater, and then into acid, and why this little stomach drama keeps every pediatric anesthetist humble. So take a deep breath, check your stethoscope, and let us begin the story of the baby with the tight pylorus and dramatic vomits. Now that we have met our tiny projectile vomiting hero, let us travel inside the abdomen to see what the real problem is. Here, you can see the stomach ending in a narrow muscular tunnel called the pylorus. In this baby, that tunnel has decided to go to the gym. It is hypertrophied, thick, and far too proud to let milk pass through easily. So every feed ends up being violently rejected, like a poor intern's first ID in the operating room. The result of this ongoing vomiting is not just dehydration, it is a biochemical disaster. The stomach loses hydrogen ions, chloride ions, sodium, potassium, and water. When hydrogen ions are lost, the blood becomes too alkaline, leading to what we call metabolic alkalosis. In the early stages, the urine becomes alkaline because the kidneys are trying to get rid of extra bicarbonate. But as dehydration worsens, the body activates aldosterone, desperately trying to hold on to sodium. Since potassium is already lost, sodium is reabsorbed in exchange for hydrogen ions. This leads to paradoxical aciduria, which sounds like a riddle, but is really the kidney's way of saying, I am doing my best under bad circumstances. So, by the time the baby comes to us, the classical picture is a hypokalemic, hyponatremic metabolic alkalosis, a long phrase that simply means every important ion is in the wrong place, and the baby looks tired. Our mission, before even thinking of anesthesia, is to make this tiny human chemically normal again. Otherwise, even the best induction drugs cannot save the day. Once we have fixed the chloride, sodium, potassium, and volume, then we can safely move to the next part, the art of gentle anesthesia in the smallest patient. Now, before we reach for our induction agent, let us remember the golden rule of pyloric stenosis: never operate on a biochemically unstable baby. The first step is assessment. Look carefully. Sunken eyes, dry lips, depressed fontanelle, poor skin turgor. These are the whispers of dehydration. And in neonates, even small losses are dangerous. We grade dehydration as mild, moderate, or severe. The rule of thumb is 5%, 10%, and 15% fluid loss. 4-kilogram baby who is 10% dehydrated has lost 400 milliliters, quite a lot, for such a small human. Resuscitation must be slow, steady, and scientific. Start with isotonic saline, 20 milliliters per kilogram boluses if needed, followed by maintenance with chloride-rich fluids. Potassium chloride is only added after we see the first drop of urine. The targets are simple but sacred: chloride above 100, sodium above 135, bicarbonate below 26, and urine output more than 1 milliliter per kilogram per hour. Once these numbers are achieved, we can smile politely at the surgeon and say, now it is safe to proceed. Remember, pyloric stenosis is not a surgical emergency. It is a biochemical one first. Once the baby is biochemically stable, we can finally move to the operating theater. But remember, this is not a race. It is a gentle ballet between physiology and precision. Our priorities are protect the airway, maintain oxygenation, and prevent aspiration. Before induction, we empty the stomach completely using the nasogastric tube in multiple positions, supine, lateral, and even a gentle prone tilt. Only then do we proceed. Induction should be calm and deliberate. Pre-oxygenate fully, then perform a modified rapid sequence induction. This means controlled gentle ventilation with low pressure, rather than a dramatic no-touch approach. Cricoid pressure is best avoided, as it may distort the laryngeal view and make intubation harder. For induction, thiopentone or propofol may be used, followed by a muscle relaxant, often rocuronium or succinylcholine if rapid control is needed. Atropine is your friend here. It prevents reflex bradycardia. Maintenance of anesthesia is with oxygen, sevoflurane, and a small amount of nitrous oxide if appropriate. Keep the baby warm. Infants lose heat faster than arguments in the doctor's lounge. Monitor glucose and temperature continuously. At the end, the muscle relaxant is reversed. The stomach is aspirated again. And extubation must only occur when the child is fully awake and breathing strongly. And of course, postoperative monitoring is essential. These babies love to surprise us with apnoea if we do not keep an eye on them. Even though the pylorus has been fixed, our job is not over yet. The baby must now safely emerge from anesthesia and begin the journey back to normal feeding. After surgery, we provide supplemental oxygen and keep the baby on an apnoea monitor for at least 6 to 12 hours. Remember, even mild residual ecalosis can make these infants forget how to breathe, so we watch them like hawks, but with gentle eyes. Feeding resumes gradually, usually around 12 hours postoperatively. Small volumes first, then slowly increasing as tolerated. Until that time, intravenous fluids must continue to prevent dehydration and hypoglycemia. Temperature control is equally important. A cold baby is a sick baby, especially in the first few days of life. If we have done everything right, correction, careful induction, gentle extubation, and close monitoring, our little patient will soon be back in the mother's arms, feeding peacefully and, hopefully, keeping the milk down this time. As we wrap up this case, let us summarize the pearls every candidate should keep polished before the exam. Number 1, remember the timing. Infantile hypertrophic pyloric stenosis usually appears between the 3rd and 5th week of life, young enough to look innocent, but old enough to make a dramatic entrance. Number 2, the classical biochemistry, hypochloremic, hypokalemic, hyponatremic metabolic alkalosis. It sounds musical, but it is deadly if ignored. Number 3, never rush to theater. This is a resuscitation emergency, not a surgical sprint. Chloride above 100, bicarbonate below 26. Only then do we start the show. Number 4, the modified rapid sequence induction, gentle ventilation. No cricoid pressure, no drama. Number 5, keep the baby warm and the glucose normal. And finally, always remember that postoperative apnoea loves to appear when you least expect it, so monitor closely, smile proudly, and hand the baby back safely. That, my colleagues, is how you turn projectile vomiting into a successful Viva performance. Thank you for your kind attention. Please don't forget to hit like and subscribe. That's what keeps us running once again. Thank you for your time.